So welcome everyone to another NJ Act Special Populations Core webinar. We're back from the summer break, and we are very excited to have Professor Coleman Drake from the University of Pittsburgh Medicaid Research Center and Center for Pharmaceutical Policy and Prescribing to talk to us today. If you have clarification questions, feel free to bring them up in the course of the presentation, but if you have kind of substantive discussion questions that you want to bring something up, we're going to have some time at the end, probably about 15-20 minutes, to try to generate a good constructive discussion here with Professor Drake. So hold them until then. At any point, bring them up and you can contact us in chat or raise your hand, and we will get in touch with you. Right now, I'm going to turn it over to Professor Hilary Samples to introduce Dr. Drake.
Yes, thank you, Jim. I have the distinct pleasure of introducing Dr. Coleman Drake. He is a health economist and assistant professor of health policy and management at the University of Pittsburgh Graduate School of Public Health. He also has a secondary appointment in the Department of Economics, and as Jim mentioned, is affiliated with a couple of research centers, one focused on Medicaid and one on pharmaceutical policy and prescribing. Before starting his position, he got his PhD in Health Services Research Policy and Administration, focusing on health economics at the University of Minnesota School of Public Health. His work has been funded by NIDA, AHRQ, the National Institute for Healthcare Management, and both the Arnold Foundation and RWJF. For his research that focuses on, as some of you may have heard at the beginning, access to care for disadvantaged populations, with studies that examine the administrative burdens and market design in the ACA's health insurance marketplaces, and the impact of public policy on opioid and other behavioral health outcomes, which we are going to learn more about today, specifically focusing on cannabis policies. So with that, I'll turn it over to you, Dr. Drake. Take it away.
All right. Thank you so much, Dr. Samples. Thank you, everyone, for coming today, taking the time out of your day to be here. I'm excited to be sharing my research with all of you and look forward to the feedback. So on that note, let me load up my slides here and get started. All right. Can you all see my slide deck here?
Yes.
All right, great. So yeah, calling this work, Geographic Access to Medical Cannabis Dispensaries, Cannabis Use, and Mental Health. This is kind of a combination of two projects, so I do plan to probably include them in the same paper, though there might be some spin-offs. We'll see. So this work was supported by NIDA under this KO1 award. And let's see. So this is the state of cannabis legalization in the US at this point. You can see here that 38 states have medical cannabis policies and another 19 have recreational. Pretty much all the recreational states shown in dark green will have dispensaries open by the end of the year, the lone exception being Virginia. Also should add Minnesota to this list. But that being said, the modal state here still has medical cannabis policy, not recreational. And the number of these states that don't have a medical cannabis policy yet are, at least several of them are likely to do so. So that rapidly liberalizing policy with respect to cannabis availability. Medical and recreational dispensaries are essentially the primary vehicle through which supply of cannabis is provided in these states that are legalizing. There are some states that allow you to grow your own cannabis at home. They, however, are in the minority. I believe New Jersey, by the way, you cannot grow your own cannabis, even though recreational dispensaries are now available. Illicit markets have continued to operate, and in some states that have imposed really high taxes on their recreational or medical cannabis, the illicit markets have grown and far outstripped the recreational markets. California is like that. Dispensaries affect increases in cannabis use, as you might expect. States with medical dispensaries see 5% increases in medical use, but without those dispensaries, there's not really much of a change. However, the effects that these dispensaries are having are surely geographic in nature, right? If you open a dispensary in Philadelphia and that's the only one available in the entire state of Pennsylvania, you're not going to have too many people from Pittsburgh driving over 5 hours to purchase their cannabis. Maybe you have a few, but there probably will not be many doing that. Existing literature, however, really only considers state variation in medical cannabis laws. This paper by Jael and Fernandez is one of them. I don't need to pick on them. There's plenty of other papers that do this, including my own. But these papers are inherently limited in that, especially when you're talking about states that are larger in just larger geographically, you're not going to see the kind of these statewide indicators for this state has a medical law are not going to kind of capture the variation that's likely happening within states when you have a medical dispensary only in the urban area or in one corner of the state or something like that. If you survey persons that participate in medical cannabis programs, and there are several studies that have done this by now, over half of them will tell you they are using cannabis for mental health reasons, anxiety, depression, things like that. However, if you then look at the clinical literature and ask, do these things actually help with those conditions? Well, the National Academy of Sciences would tell you there is limited evidence that there are mental health effects. This is perhaps complicated by the fact that CBOD can be anxiolytic and THC can be anxiogenic. So you get both those ingredients in most in cannabis that you would buy at a dispensary. You can't get CBD only, but there's plenty of people that are using the kind with THC. I see the kind that gives a person a high. So you have literally contrary effects biologically based into the substance. So that's kind of confusing. It seems like there is some, the literature is a little bit rosier on effects of cannabis for PTSD, but it is also very negative on effects for developing psychoses, persons that are prone to have psychoses. If they use cannabis, particularly when they are younger, that is not good. Overall, though, the mental health effects, as you can see here, pretty ambiguous. Like I said, clinical literature is all over the place. There are a couple studies that use observational data with causal inference methods. One found that medical cannabis improves mental health using Burfus data. A more recent one found recreational cannabis literature recreational cannabis laws have a similar effect, though they only found that for women, I believe, aged like 35 to 54, no other groups. Yet another study found that there were clear increases in mental health related observations in Colorado after they legalized, and a recent study by Rosie Lopakala found increases in psychosis related hospitalizations. So again, we kind of have a mixed bag when we look at the more econ type literature here. Excuse me, this was a previous slide I meant to delete, so I'm not going to worry about that. So the research question I want to ask today is, how does geographic access to medical cannabis dispensaries affect cannabis use, mental health, and related downstream hospitalizations? I'm going to go over my empirical approach next, and then talk about results and do a little bit of policy discussion. And I want to make sure we have about 15 minutes for questions at the end. Again, if anything I say here is not clear, please feel free to interrupt me, and I'd be happy to clarify. So what I'm going to do is use two somewhat similarly motivated approaches in two similar states. First, I'm going to study how access to medical cannabis dispensaries affects cannabis use and self-reported mental health in Ohio. This uses Ohio Burfus data, which contains more granular geographic information than the national Burfus data. Ohio opened its first medical cannabis dispensary at the tail end of 2018. Effectively, you can think of that as the start of 2019. And their Burfus data from 2016 through 2020 contains about 35,000 respondents, so pretty nice sample size there. I'm then going to look at Pennsylvania data, Pennsylvania hospitalization data. This is the universe of Pennsylvania hospitalizations, data that's very similar to that you would see in the HCUP or state inpatient databases. Pennsylvania doesn't participate in this data to give researchers more headaches. I'm not really sure why, but you can get it. And they opened their first dispensary in 2018. And I see 1,017, sorry, pronouncing numbers is hard today, apparently. 1,784 zip codes over 19 quarters with that data. So like I said, got this purpose data for Ohio. We can see patient zip codes in there, or rather respondent zip codes. That's fantastic. They also surveyed people on cannabis use in 2016, 18, and 20, but not odd years. So far from ideal, but certainly better than nothing. About 7,000 people per year we're seeing here. The Ohio Department of Health provides a listing of all dispensaries, medical cannabis dispensaries that have been opened in Ohio, the date they were opened, and the address they opened at. That's fantastic. That's exactly the data I want. And by the way, dispensaries don't really seem to close. They will change ownership sometimes, but if a location gets a dispensary, it keeps a dispensary. That could change, but this is a growing market, to say the least. In Ohio, I want to look at whether people, cannabis and mental health are both reported in terms of past month. So did people report having any poor mental health days? How many of those poor mental health days were there? And did they have over 2 weeks of them? Same thing with cannabis. Did they use it? How many days did they use it? Did they use it for over half the month? This is all self-reported, but we tend to think that self-reported mental health, based on the literature, a pretty solid measure of mental health, actually. And here's what our exposure is. How long does it take you to get to the nearest dispensary? What is drive time to the nearest medical cannabis dispensary? Prices don't vary a lot across dispensaries. So if you want access to a medical cannabis dispensary and you're in Ohio and that has a qualifying condition, this is basically a measure of what is the travel cost for you to reach a dispensary. On the left, we see what access looked like in April 1st, 2019. And it was not really good for most Ohioans. Huge driving distances if you live in Western Ohio. And if you're familiar with Ohio geography, you do kind of get it's like Cleveland is in the Northeast. I don't think I have the little thing on my, I don't have the ability on my, I don't know how to create a little blip on the screen to show you, but regardless, you see this dispensary in the northern part of the state up here. That is not Cleveland. That is like an hour west of Cleveland in Sandusky. So when dispensaries were opening in the state, you had the state's, I believe, biggest metro area. I'm biased. It's also the best metro area. It's where I'm from. And the Cavaliers are the best team ever. But Cleveland did not have great access. Columbus, you're not seeing that second dot on the kind of north central, a little bit to the east part of the state. That's not Columbus either. That's like an hour east of Columbus. And Cincinnati's in the southwest, and there was nothing there. So this was not.
If you want to use your mouse, I think we can see your pointer when you move it around. Yeah.
Oh, you can see this?
We can. Yep.
Fantastic. Oh, thank you so much. Okay, so yeah, like Cleveland is here, Columbus is up here, and Cincinnati's down here. So we didn't get this case of the big cities get access to medical cannabis before everybody else, which is really nice for my experimental design. For some reason, Steubenville, Ohio, home of Dean Martin, got 3 medical cannabis dispensaries pretty much before anybody else. I have no idea why that happened, but licensing process is kind of obscure. I don't know if somebody in Steubenville was friends with somebody in the Ohio Department of Health or like a state legislator or something, but anyway, that's what happened. By October 1st, 2019, you're starting to get a lot more kind of variation in geographic access here. Dispensaries are opening up. And then in 2020, things are really kind of saturating, at least in the bigger cities, though we still have plenty of these areas throughout Ohio where there's not much access. You get Athens, Ohio down here, decent sized population with no access, and most of the other metro areas by 2020 are pretty well saturated, but it wasn't
How
like
can
that
all
initially.
those students in Athens survive?
Well, it is a really pretty campus, and they
Okay.
do have a good calzone place there, so they got that at least. They're also not eligible, by the way. You have to be 21 for a medical cannabis card. So I guess the June, could be affecting some college students, and then you can resell it. But with the fairly restrictive list of qualifying conditions, this is usually not available to college students in Ohio. Not the case in other places necessarily, but not how it works in Ohio. My statistical approach is pretty straightforward here. I model those outcomes I described to you, mental health and cannabis use, both as a function of drive time to the nearest dispensary and a number of covariates. So I just lump everything in X here, respondent sociodemographic covariates. Think of this as stuff you usually include in a regression: age, sex, race, income, rural, urban, all that good stuff is in here. I also include time fixed effects. And then, I think I should have added a little thing here. I don't use like county or zip fixed effects. Sample size is not quite good enough for that, but I do use region fixed effects. So like Southeast Ohio or Central Ohio will have their own kind of indicator, capture regional differences. And I capture a lot of the kind of neighborhood stuff with like income and unemployment, et cetera. And then I have a zip code clustered error term, since we're essentially the treatment is the same for people living in a given zip code at a point in time. So pretty standard linear regression there. I also use an instrumental variables approach to try and get at causal effects on mental health. Idea here is that drive time to the nearest dispensary affects cannabis use. That cannabis use in turn affects or could affect mental health. What makes this a nice IV design is that presumably how close you live to a medical cannabis dispensary is probably not directly affecting your mental health. The only way that could affect your mental health is if you purchase cannabis from that dispensary, and then that in turn has an effect on your mental health. So I use that intuition to construct this instrumental variables design. I'm not going to go into super detail on that here, but happy to answer questions about it at the end. But it's basically the causal relationship is derived from the fact that we can't draw an arrow here from dispensary access to mental health except through cannabis use. And that enables us to use variation in cannabis use that's affected by dispensary access to extract a causal relationship between cannabis use and mental health. So that's the Ohio approach. Now I'm going to go over the Pennsylvania approach and go through the results. The results kind of snap together real nice, but just bear with me for a minute while I go over the Pennsylvania approach. So Pennsylvania data, like I said, Pennsylvania healthcare cost containment data. This is just hospitalizations in Pennsylvania, and I see patients' home zip code. There are a lot of hospitalizations with anxiety and depression related diagnoses, and that is what I am looking at here. I use Pennsylvania Department of Health dispensary listings, just like I did for Ohio. They provide effectively the same exact information, and then some other standard data sources for additional covariates like local unemployment stuff. Same as what I did in Ohio. Outcomes here, we do see individual hospitalizations, but we don't see people that didn't get hospitalizations. So what I do instead of estimating a model at the person level is I estimate counts of hospitalizations at the zip code level. And I look at hospitalizations that are related to anxiety and depression, and then I also look at a few that are related to cannabis. Generally, when we're talking hospitalizations, there are cannabis-related hospitalizations, particularly like polysubstance use and stuff like that, but they're relatively rare for people to just have a straight cannabis-related hospitalization. Usually they'll just throw you in a hot shower in the emergency department and keep you there until you're calmed down a bit. But what is more common, however, is hyperemesis, which is uncontrollable vomiting. And that's typically happens when people have too many edibles. They don't realize their dosage and then have a very unpleasant experience after that. So that's kind of a more...
Coleman, these Ohio hospitalization data do not include ED?
The Ohio hospitalization data, Ohio hospitalization data are extremely hard to get. Pennsylvania, yeah, no, they don't have the data, which is
They don't
really
have something like a universal billing for EDs.
I'm not sure what you mean by universal billing, but they essentially
Well,
don't
in
have
New
a
Jersey,
set.
apparently there's an UB process whereby the hospitals report all of their encounters, including those in their EDs. But I don't know whether there's other states where you could get that. You might be
Yeah,
able
there's
to get
a-
it in New Jersey.
Yeah, there are a lot of other states where you could get that actually. You know, you can look at, I mean, in one sense, like there's the look at the H-Cup data where there's the hospitalization and the
Right.
ED data and see which states have it, and some have none. A lot of them have both. Pennsylvania, unfortunately, is only in the business of reporting their hospitalization data and not their ED data. I hope that
Right.
changes, but
Right.
that's not the case right now.
Right.
And I'm kind of torn about it because it's very Ohio and Pennsylvania, you know, similar states, similar medical cannabis programs. That's very nice for the purposes of this analysis. But at the same time, it would sure be nice to look at ED data rather than hospitalization, where there's more ED visits, and there's particularly more ED visits for like cannabis and some of these things. So yeah, thank you. Could do this analysis in New Jersey, but they've been a little more ahead of Ohio and Pennsylvania in terms of their cannabis policy. So I fear, and two, in terms of like comparing to Ohio, I don't think New Jersey is nearly as good of a comparator as Pennsylvania is for that state. And I should mention that getting this BRFIS data that has the zip code level information, that's really hard to do. I think Ohio and Washington are the only two states where I've been able to get that kind of thing from.
Yep.
So, yeah, you're most welcome. So Pennsylvania, same kind of idea here. This is another map similar to what I showed you in Ohio. This is more based on, I think this is when did Pennsylvania zip codes gain access to a 30-minute drive of a dispensary, but that's just the map for this purpose. I'm using the kind of exact same measure I did for Ohio. And you can see quite a bit of variation here, though Pennsylvania was kind of more one of these stories of like the urban areas get access quicker than the non-urban areas. By the way, this is just a shot of if you go on either of the state's websites, kind of what you're going to see, where you can literally click around on a map and see where each dispensary is located. This is an example of one very close to downtown Pittsburgh, downtown being on the bottom here, and this area called the North Shore, which is still very much like a central urban area on the top here. And Harvest of Pittsburgh opened on October 21st, just a block down the street from the Andy Warhol Museum. Take from that what you will. And the zip code was 15212. It's also right next to the baseball stadium. So a very kind of central accessible dispensary, but you can see this kind of information for any dispensary in the state of Pennsylvania. And you can easily turn this data into I think they just flat out provided like a spreadsheet that you can download. So in any case, in Pennsylvania, I want to estimate causal effects again, but I don't see that relationship of dispensaries affecting cannabis use affecting outcomes. What I do see is all this geographic variation in areas that have dispensaries over time. So I use this, it's called a binned regression specification, which is essentially, rather than estimate a model that has just a term for like linear drive time, whether you're 20 or 30 or 40 minutes away, the 10 minutes is going to have the same effect. And instead use this binned approach, which cuts drive time into as small of little units as it possibly can, given the sample size, and then is able to compare like, okay, what's the difference in drive time in a non-parametric way between like 5 to 7 minutes from a dispensary, 7 to 10 minutes, 10 to 12, and gives you all these different little mini treatment effect estimates of how dispensary access affects hospitalizations for mental health and cannabis. And what's nice about that approach is it can kind of serve as like a geographic analog to diff and diff, where you end up with this comparison group. The comparison group here is areas that are essentially too far away from a dispensary to have for there to be any effects on their mental health related hospitalizations. What's nice about that is you are assuming that there is such a place, that people that are 2 hours away from a cannabis dispensary are just not going to use it even if they have a qualifying condition. But as I'm going to show you on the results here, you can literally see that on whether that's happening in the results. If it is, if you have a comparison group that is not being affected, you effectively have this kind of diff and diff setup where you're looking at, okay, what was mental health related hospitalizations before medical dispensaries went online, and what's it looking like after in areas where they were close by and were not close by. If that's a little unclear yet, just hold with me for a minute, and I think it's going to be real clear when I show you the results. But that's kind of the intuition behind this approach. Right-hand side variables, kind of the same things you'd expect normally, and that I included in the Ohio results. I also included some measures of demand for opioids and potentially other substances in terms of cancer and arthritis hospitalizations. People might just be using cannabis because they have cancer-related pain, which is a very common reason to use cannabis, and also one that is deemed to be clinically effective.
Coleman, before you move on, we have one just clarifying question in the comments about the methods for drive time. Mila Dunbar, I hope that I pronounced your first name right, asks if access is measured by driving time only, like assuming a person has a car, or if public transportation is included.
Yeah, so that's a great question. I have a paper on that subject on access to buprenorphine prescribers, actually, but it's unfortunately not something I can cleanly incorporate here without complicating the models quite a bit. So this is based on drive time. I'm going to argue that I'm fully supportive of research that points out that, like, I mean, again, I've done it myself, that like when you're talking about access to healthcare in urban areas, particularly for Medicaid enrolled populations, it's a very good idea to not consider cars as the only form of access, or what people are obviously using, because about half of Medicaid enrollees in urban areas do not have access to a car. But in this case, medical cannabis cards cost a couple $100. Medical cannabis itself is more expensive than illicit cannabis. This does seem to cause people with lower incomes to stick to the illicit markets because if they want to use cannabis and can't afford the medical stuff. So I think for most people in question in this study, drive time is going to be a pretty valid measure. And I should say that the drive time measures I use here, which is kind of like the back end on ArcGIS. So it considers like road structure, traffic lights, speed limit, congestion, all that good stuff.
I think that answers my next question, which was a follow-up to that, how you identified minimum drive time. So it just is, you're just assuming no traffic.
I think we typically, the analyst that I work with typically assumes like, what does it take to get to a place at 9 a.m. on a Wednesday to kind of try and capture typical traffic conditions.
Thank you.
Yeah, you're welcome. So yeah, there's still a little room to like be like, well, maybe in areas like it's unusual, like congestion patterns are quite random and people account for that. And like, I can't get that far, but I can account for typical congestion. And then the rest of it's good. Although you do get these, I'm sure you're no strangers to this in New Jersey, you do get the never-ending construction project sometimes. So Cleveland, I can attest Cleveland and Pennsylvania have plenty of that. Anyway, want to get through my results and discussion so we have time for questions. Here you can see blue line, I apologize, no legend. Blue line is percent of people reporting any poor mental health days in Ohio over time. Kind of a slow linear increase over time between 2016 and 2019 when cannabis dispensaries opened. You can see cannabis dispensary volume with the red line increasing pretty steadily throughout 2019, curbing off a little bit with the COVID pandemic. And then you can see cannabis use, again, only reported every other year, is increasing over time. Primary findings here. So I have on the leftmost column, my cannabis use and poor mental health related outcomes, any use, number of days used over 2 weeks. And then we have the baseline means for those characteristics. Those should not have the significant stars next to them. That should just be on the right. So I apologize about that. So ignore those stars in the second column. But what we're seeing here is that 9.6% of the people in the Ohio BRFIS are reporting any cannabis use within the last month, 1.5 days typically. So not typically the mean cannabis person using cannabis, not doing it a lot of days. And then the people using over 2 weeks, very low. Though I should mention these are like population among the whole population. So it's going to be higher conditional on cannabis use. Poor mental health days, nearly 40% of BRFIS respondents reporting some poor mental health days. And even when you do the population mean, you're getting 4.5 days on average. But I don't imagine that's terribly different than the national average. And then our results are shown here in the rightmost column, where we're seeing the percentage point change associated with having 30 minutes decreased drive time to a medical cannabis dispensary. So what this is telling you is that, okay, you live in Ohio in 2019 and a new cannabis dispensary opens 30 minutes closer to you rather than the one that was previously available, like what happened then in any of the major cities in Ohio in late 2019. And we would expect a 2.2 percentage point increase in cannabis use, about a 20% increase in cannabis use when those dispensaries get closer. So these things are absolutely having an effect. They're also increasing.
Are these diff and diff calculations?
These are just pure associations. These should not be interpreted as causal on this slide. Thank you for clarifying. So this is just pure association between drive time and the outcomes. And we're seeing that all these different measures of cannabis use, we are seeing they're associated with increases in cannabis use when we get 30 minutes closer to a dispensary. We're also seeing this increased association. I'm trying to avoid causal language here as I speak, with increase in poor mental health days. So at least these associations are painting a picture of increased cannabis use and increased poor mental health days, at least on the margin between having none and having some, though not necessarily between more for people that already have them. Now, if I implement that IV approach that I described earlier in Ohio, we do find that there appear to be effects here. So same kind of cannabis use results as we saw before, those not necessarily to be interpreted as causal. However, what is to be interpreted as causal is that cannabis use is associated with, or in this case, if you believe the assumptions, causes a 1.03 percentage point increase in poor mental health days. Still no changes in days of poor mental health. So you might call that an extensive margin result that cannabis use seems to be increasing poor mental health days, or at least cannabis use within the context of the Ohio Medical Dispensary Program during 2019 and 2020. 9 months of that was during the COVID pandemic, so there's some ecological differences going on there. Standard IV tests perform very well, by the way. I hope I convinced you the setup is reasonable, and the standard IVF test for is the first stage instrument good? The answer is it's very good. So that's the initial finding there. Not a good picture for mental health. Pennsylvania, taking a look over there. Dispensaries have increased in a linear fashion since 2018. Here's our first results looking at vomiting nausea hospitalizations. So this is essentially our main proxy for, are we seeing an increase in cannabis-related hospitalizations? And what we're seeing here is that, like, if you live 0 to 10 minutes from a medical cannabis dispensary, there's this negative association, but we can see in green, there's this confidence interval. It does cross 0, and these estimates appear kind of noisy. Things zero out at about 50 minutes, though, again, all these effects except this one random one are not appearing like there's a lot going on here. Cannabis-related hospitalizations, same story, really noisy. Anxiety, same story. However, Depression-related hospitalizations. We're seeing that people that live in about 15 minutes away from medical cannabis dispensaries, on average, an increase of 75 hospitalizations with depression-related diagnoses happening in said zip codes. This relationship maintains to about 25 minutes away from medical cannabis dispensaries and then starts to zero out. So this is what I was talking about with this kind of this model working, this bin approach working as a diff and diff approach, is we need to see this kind of zeroing out for us to believe that these treatment effects are actually happening. But we do see that here. Once you hit 25 minutes, we're getting a bunch of these little estimates that are saying there's really not an effect going on. What that suggests effectively is that A, there is actually an effect, and B, the effect is within about 25 minutes. Notice I avoided specifying a model that made any assumptions about how far these effects actually occur at. And this model, these results are effectively telling us that within 25 minutes of a medical cannabis dispensary, zip codes that are in that distance, we are seeing an increase in depression-related hospitalizations. This story is also consistent with this increase in poor mental health days that we're seeing in Ohio. So I was, to be honest, a little skeptical of both of those sets of results, but then I saw them together and was kind of like, oh, there really might be something going on here. And those are the results. I got about 5 minutes left before Q&A, so let me go through the discussion. I'll kind of offer my thoughts on these findings, and I would love to hear yours as well. So a little summary of the results, just to restate. Ohio results are consistent with an increase in cannabis use associated with dispensaries. My estimates aren't causal, but there's plenty of papers that do have causal estimates, and it is consistent with them. Also, it's pretty darn intuitive. Pennsylvania, we're not seeing that increased cannabis use, presumably also happening in Pennsylvania, is translating into an increase in anything that could be associated with cannabis in terms of hospitalization. So we could say that there's like no direct effects here. However, this paper, this work, I think is kind of more about cannabis effects on mental health, where we see in Ohio that there's this association between dispensary access and decreased mental health. That's not causal, but we see this causal relationship between cannabis use worsening mental health with that IV model. And then we also see in Pennsylvania that dispensaries affect increases in depression-related hospitalizations. Presumably, if we had the data from just all this data from one of these states, we would be seeing this relationship throughout, but of course we can't know that without doing the analyses on data that are not available. So I'm sad about that, but I'd stress that these are two similar states with two similar medical cannabis programs. Although these results do not paint a good picture for cannabis liberalization and mental health, I do want to stress that my results are an average effect, and that these results are also a policy effect, not a biological one. So although this would be consistent with the story of the cannabis use is not good for your mental health, it is not a story about the biological effects of cannabis on mental health. I'll leave that to people that are not economists, physicians, biologists, etc. And then what I think is exciting about these results is that I do provide causal estimates on something that there's been kind of a lack of causal estimates on, this relationship between cannabis use and mental health. Let's see, I guess this speak to the second point. I would just further stress that this is this is like a Midwest, whatever census region you want to call Pennsylvania set of results. And that we might expect to see different things in states that implement recreational cannabis laws as well. So moving forward, to the extent I can, given sample size, I'd like to do subgroup analyses. Certainly could do that on sex, race, ethnicity. Gets a bit harder when you consider that once you get outside of urban areas in these two states, there's not super large minority populations. Also look at some additional outcomes, and look at these results with a lot of robustness checks. Also get another year of data from Ohio. And then where I'd kind of like to close off this analysis is say, hey, what would we expect in terms of mental health effects if everybody could access a dispensary within 20 minutes? What would that look like in terms of mental health, cannabis use, and mental health related hospitalizations? And what might these states expect or be currently experiencing given the data lag we're experiencing? There has been, Pennsylvania, by the way, anxiety is a qualifying condition for medical cannabis. I think these results might kind of question whether that's necessarily a great idea. That being the case, chronic pain is often kind of a way that people can get these cards regardless of whatever else is going on. It's a fairly easy diagnosis to get through the system, but regardless, should be, if anxiety is not, it is not on average benefited by this system, should we treat it as a qualifying condition? It also kind of asks like, okay, we need to look beyond necessarily, even if there's no cannabis related effects in terms of downstream health outcomes here, are there mental health, are there mental health or other substance use related ones kind of need to be considered when deciding how states should move forward on cannabis liberalization. And then two, like I said a moment ago, and I'll finish on this thought, is that the effects that I'm picking up here are average effects. If there are different conditions for which cannabis is very effective, patients experiencing pain related to cancer, the National Academy of Sciences is very on board. Cannabis is an effective treatment for that. If I had a child with epilepsy, I would very much, to my understanding, want to provide them with cannabis to relieve those symptoms. So I don't mean to cast these results as a uniform negative at all, even for mental health conditions. PTSD, like I said at the start, potentially helpful. So I caution you all and myself and everyone else that I present this research to make kind of broad generalizations with it. But regardless, average and net mental health effects are very important to understand. So thank you all so much for your time, and I look forward to your questions.
Thank you. If anyone has questions, you can ask them now. I have a couple, but I will hold off.
We have one in the chat. Boriana Milucheva asked, she said she was wondering, is the implicit assumption in the strategy that dispensaries are locating in a way that does not account for the expected demand for their product?
Yeah, so that's a great question. Implicit in especially the kind of more DD design for the Pennsylvania approach, where if there's a unobserved variable that is systematically related to both the treatment drive time and the outcomes, then that would bias the results. So I suppose my response to that is maybe there's an expected demand component. You would certainly think businesses are responsive to expected demand. But at the same time, there is the process for getting your cannabis dispensary open in Pennsylvania, or really pretty much most states, is extremely convoluted, a lot of red tape. Whether your dispensary opens sooner or later, i.e. is in the treatment or you're in the treatment or the comparison group at a certain point in time, that all varies a lot, subject to state regulatory policy. So I suppose I can't entirely refute your concern here, but I would argue that basically the bureaucracy is kind of the primary driver here and is as such helping my study design. You're welcome.
I'm sure there are other people collecting their thoughts. I have a few thoughts, but others should go first if you have questions.
I have a question. In your hospitalizations outcome, was that expressed as a raw number or as like a rate?
It was a raw number.
Did you
Yeah,
you use something to account for like the population in the area? I'm guessing in your modeling approach.
Yeah, absolutely. I get a little, I always get a little, I know it's done often, but I get a little antsy doing rates as outcomes, because I mean, like if your denominator is like state population, like, yeah, that's not going to change that much over time. Zip codes could change a little more. And I don't want to be modeling changes in the denominator and then confusing that with changes in the numerator. But that's, like I said, sometimes that's not always it's not a categorical reason not to do it, but particularly when I have this non-parametric approach for Pennsylvania, I'm kind of more at liberty, I think, to model counts without worrying about it too much.
Thank you.
You're welcome.
So these were very rich analyses, very clever strategies to seek out data sets that could give you, they don't quite give you everything you want yet. It would be ideal if you could get a state where you have the zip codes and the ED data.
Yeah.
And the,
So,
yeah.
oh, go ahead, I'm sorry.
Go ahead.
Oh, I was just gonna say, Washington State kind of does provide that. I'm a little, it's not a state that's been hit as hard by the opioid epidemic. Although I guess here I'm just kind of looking more at mental health. So that's that I was looking at opioid stuff for a while. With this still want to. And then that too, it gives more of a lens into either what medical programs were doing like 7 years ago or what recreational programs are doing now, though that's interesting. Obviously how recreational programs are functioning now. It's getting a little hard though with how recreational programs are functioning now, because like they'll open up and then you'll get dispensaries offering delivery programs and the black market will proliferate. And then trying to use these like isolated geographic effects is kind of hard. Where like in Ohio and Pennsylvania, what's nice is like you can't grow your own cannabis at home. That's super illegal. The penalties for having cannabis outside of the medical program are severe. Pennsylvania, I believe it's a felony outside of Pittsburgh and Philadelphia. So like the kind of stability, I do like the regulatory regimes in these stricter medical states they kind of help my research designs. So I'm conflicted, but that doesn't stop me from it. I still want to do the analysis with the Washington data.
So that sounds like a good, promising step forward. I'm assuming that New Jersey does not have zip codes. I haven't heard of it having zip codes with its purpose, but there are so many things going on in each of these states. So the big challenge for all of us is trying to distinguish the signal from the noise.
Yeah.
So I'd be interested in any other thoughts that you have as to how you might start persuading policymakers that this type of evidence is robust. And it was a lot empirically to digest. The outcomes that come from the BRFIS, those are self-reported mental health outcomes.
Yes, and cannabis use.
And the finding between cannabis use and they didn't find any association between cannabis use and poorer mental health. Is that right?
No, I mean, in the Ohio,
I remember.
IV result is there is the decrease in
the IV result has a decrease in mental health. So that maybe is something that you want to really dig into further and see, for example, if it can be replicated in other states. And in some ways that's sort of more proximal on the causal chain. In other words, when you think about the policy effect, the policy effect presumably operates through cannabis use.
Yeah, no, that's kind of like with the I actually had seen the the hospitalization results in Pennsylvania first, and it was like, it was removed enough that it was kind of just like, okay, that's a result, but that really, I think together they're so much stronger when you can see that causal chain happening of cannabis use, poor mental health, depression-related hospitalizations.
Right, exactly. And that's one of the ways that you start making the results more persuasive. I mean, this is characteristic, I think, of the whole field at the moment, is that there is just a ton of confusing results that seem to vary by location and vary by a lot of other things as to the effects of changing marijuana laws. It's an extremely confused, and I love the idea that you're going, because so much of the research has looked at state policies, and when you look at state policies, you only have 50 cases. So and you're just trying to, and you might have, 50 different kinds of policies and 50 different other factors that you want to account for. There's just maybe not enough carrying capacity in the data. So this idea about using this natural experiment, I think intuitively it's just where you want to go. Boriana has a comment.
Yes, I saw Google Trends data, and I'm already getting excited to read the rest of this. Google searches for things like cannabis overdose symptoms or other mental health crisis response terms at a granular geographic level may help to further support the rest of this analysis. May help you branch out the analysis. So I love that idea. Boriana, do you know what level of geographic granularity can you get with the Google data? And I'm just asking out of like high level of ignorance. I've seen these data used, but I've never touched them myself.
I think you can get it down to the county level from what I've seen. And I suspect that if you reach out to Google, they might be able to give you something even more granular.
Oh, now that is exciting. Okay. Yeah, it seems like those Google Trends data are being used everywhere. I was trying to take a note on that. Yeah, that would be interesting. And like, county's not perfect, but certainly that could be a nice kind of supplemental thing. Did your depression hospitalizations include suicidal self-harm? So the way I measured a hospitalization was added to the count for a given zip code if one of the diagnoses on the hospitalization was for depression. And I did use very standard, I forget what off the top of my head, but like there's very standard kind of ICD 9 and I think where it was all 10 by the time I was doing it, coding schemes for like, this isn't a depression related ICD 10 code. So that's what I used. So I feel confident with like using an established scheme, but what I feel less confident about is the okay, is this a primarily depression related hospitalization, or is this just like a secondary thing that the patient already had going on and they coded it for that reason? So if you have some thoughts about that, I'd love to hear how to address that. If you don't, that's okay too. I'm not sure I have the best answer myself.
Yeah, I'm not sure I have any thoughts. It's just suicide's an interest of mine, so I'm curious about it.
Yeah, no, I definitely, what I would like to do here is add suicide as an outcome. I think, certainly the considerably lower frequency than depression, though that being said, unlike cannabis, like that's going to get you hospitalized more readily than somebody shows up in the ED with suicidal ideation. That's much more likely to get translated to a hospitalization than a cannabis overdose.
Yeah, that was part of my thought process, is you might actually have higher numbers.
So Coleman, I think that's yet another reason why it would be so exciting to get the ED data into it, because these self-harm events that are treated in the ED are not uncommon. And if you look up some of Mark Olson's papers, you see, you get some sense of their frequency and what their, what their implications may be. So
Yeah.
that would be another outcome to, if you had to make up a clinical story or look for clinical literature to support the scenario of increased medical cannabis access leading to more depression hospitalizations, have you thought of like what kind of literature you might turn to? Or what kind of scenarios you might point to add credibility to that association?
I guess, I've looked at the literature on, like I kind of went over at the start, I went over at the clinical literature on effects of like cannabis use on mental health. But I guess I'm a little less, so my bread and butter is the econ stuff, but
Right.
that's thoroughly unsatisfying often in the sense that like you get these diff and diff that shows like X causes Y, but why does it cause Y? And then
Well, oftentimes one can find a clinician to help you tell that story.
yeah, so that would be, so I did talk to, and I need to follow up a bit. I work with a clinician who's the head of UMC psychiatry, and he's also on the medical cannabis board for Pennsylvania, Antoine DeWahy. And I started to ask him about this, and he was telling me, he kind of went over, I was trying to go after that question of like, what do people show up in the hospital? Like, what does a depression-related hospitalization look like? And his responses were generally kind of these things that made me feel like, okay, like this is doing this any depression coding scheme that I'm currently using doesn't seem like an insane thing to do. But I'd love to ask him some more, or if Russ, you have some thoughts too, like what's a narrative or what's a case where this kind of thing might happen? Would be
Well,
great.
some of the psychiatrists, some of our psychiatry colleagues who are really worried about marijuana might have some thoughts about that. Nina Cooperman is one that we work with that has those worries. Peter, who else? Who are the other psychiatrists that we work with that worry about that? But you can definitely, excuse me?
I'm not sure, actually. I don't know anybody's perspective on that.
But there's a lot of, there's a lot of sort of message board kind of things that, psychiatrists worry about these things. The things that psychiatrists worry about most often is young adults who are fragile and may have tendencies towards psychosis, but the idea that heavy marijuana use could become a kindling factor for psychosis. So they, based on sort of biological reasoning grounds, would be looking for those earlier hospitalizations with psychotic type symptoms.
This is great. I want to be mindful of everyone's time.
Right.
I think we could talk about this all afternoon, but we are a minute after. Coleman, thank you very much for coming to present your work, and thanks to everyone who attended. I think you had your contact information, and we have that in JAX, so if anybody wants to follow up, they can do that too.
Wonderful. This was fantastic. Thank you so much.
Oh, thank you all so much. I really appreciate the great questions. This is like, really, I think it was clear that like, this is preliminary. This is research that's coming together, and it was so useful to get some feedback as I think about how to take this to the next step.
Great. Thanks.
Great.
Thank you.
Thank you so
back
much.
when you're at that next step.
Thanks, everybody. Yes, that sounds great. All right.
All right.
Take care.